Hello and welcome to another episode of caffeloguewithNaga, where we explore the people, passions, and professions shaping the world around us. I'm your host Naga, and today we are diving into a critical area of healthcare that often doesn't get the spotlight it deserves: pediatrics and pediatric rheumatology. Being a parent of two young children, pediatrics has been part of my personal journey for the last 10 years, with my children growing up. So I was always fascinated by the pediatricians and how they approach children. While I have great respect for all the doctors around the world, pediatricians play special or have a special place in every parent's personal life, because it's important to have that trust when you actually take your children for consulting, and especially building that connection and trust beyond just being a pediatrician is very important. So I strongly believe that pediatrician plays a vital role in every parent's journey. Especially, your children should have the confidence and trust, believing that they are not outside the family, they're part of your family. I had the privilege of actually knowing one such pediatrician and an inspiring woman, Dr. Jyothi Raghuram. So I am happy and honored to have her part of my show today and talk about her area of practice, pediatrics and pediatric rheumatology. So joining us today, our esteemed guest, Dr. Jyothi Raghuram, a dedicated, a well-known pediatrician in India with specialized expertise in pediatric rheumatology. So Dr. Jyothi brings not only clinical excellence, but also deep compassion to her work with children facing complex autoimmune and musculoskeletal conditions. So Dr. Jyothi brings more than 2 decades of experience in pediatric and pediatric rheumatology. Her special interest in rheumatology led her to the certification from European League in Rheumatology and trained in Bristol, UK as an observer in 2016. So currently she's practicing at Aster Women and Children Hospital in Bengaluru. She's done a lot of great service in the field of pediatrics and in the field of pediatric rheumatology. Her service mentality is something which is beyond words to describe, and beyond the regular consulting hours she's putting in the hospital where she practices. She's also doing honorary work at a pediatric rheumatology clinic in a territory level government hospital once a week. She's a continuous learner and has been on the digital platform actively providing critical information to parents and questions related to pediatrics and pediatric rheumatology for more than 10 years. She's the top scorer in general medicine. She has also presented scientific papers in numerous conferences. She has won prize for best oral paper in pediatric rheumatology at National Conference of Pediatric Rheumatology in 2022. She has a lot of publications and index journals and contributions to chapters in pediatric and pediatric rheumatology textbooks. A life member of Indian Academy of Pediatrics, a life member of Pediatric Rheumatology Association, executive member of Pediatric Rheumatology Society in India, and recently appointed as treasurer, part of the office building committee, an executive member and founding member of Indian Society of Kawasaki Disease. In today's episode, we will unpack what pediatric rheumatology really involves, how it intersects with general pediatric care, and why early diagnosis and awareness can make a world of difference for young patients and their families. Whether you're a parent, a medical student, or just curious about this fascinating field, stay tuned, and this is a conversation you won't want to miss.
Pediatric rheumatology as a subspecialty was fairly nascent in between 2000 and 2010 in India, but now there is a lot of growth in this field. More and more youngsters after passing out from pediatrics are choosing pediatric rheumatology as a subspecialty.
Sometimes the children is not able to even say that why the pain is, because they've not really heard, or probably they didn't get into any kind of an impact which is actually causing the pain. So it is difficult for them to say.
So the younger children may present with a painless limp actually, and some children may present only with inflammation in the eyes, which is not picked up. And now there's an explosion of information, right? So everything, not just Google, there's ChatGPT, there's so many AI platforms where anything and everything will be available at the click of a button.
Yes.
And like you rightly said, overexposure and over Googling can actually lead to a lot of false panic or reassurance sometimes amongst parents.
Now the biologics have come into play, is actually helping the industry a lot.
Biologics have been game changers. They are expensive drugs, so we have to help out these families in being able to procure this medication.
But so all these will start with more of an inflammation, or it starts with an infection.
Immune system, there has to be a fine balance between recognizing the foreign antigen, fighting that foreign virus or bacteria which attacks our body, and immune tolerance. Immune tolerance is where the immune system doesn't attack the host or the own body tissues. When this balance is disturbed for some reason, that's when the autoimmune diseases start.
How much of the cases you have seen, probably 1 in 10 children you see that is a common inflammation allergy?
Yeah,
Or
very common. I think 1 in 5, I would say, because they may come as cold, cough, fever, but we'll have to actually take a detailed history to see if it's allergy, if it's infection. Viral infections can trigger allergies.
In India too, you're seeing that the allergy pandemic is on the rise. Why the rise is happening? Thank you so much, Dr. Jyothi, for joining another episode of Caffelog with Naga, and I'm so happy to have you and privileged to talk to you about your specialty and your practice, pediatric rheumatology. While we deep dive in the rheumatology, but will also ask about especially your 3 decades of experience in the pediatrics, and as well as you've been a neonatologist earlier. So thank you so much for doing this on this Sunday, and I'm pleasure to meet you again and talk to you.
Thank you, Naga, for having me on your show. It's a pleasant surprise to see this side of you. I've only seen you as a parent, sometimes worried, sometimes not so concerned when you bring in your kids.
Some of the people I heard very inspiring when you meet them, and when you beyond the service, beyond you see the kids. As a parent, the important point is how much you're having a trust on the doctor, how much you can blindly listen to whatever the doctor says, and you feel that confidence. Okay, he or she is there to actually take care of your children. So well-being of the children is the important aspect of any parent. So in that way, your warmth and your comfortness, I think my daughter, my son, both of them loves you so much. I think by the time we visited, and they were so there's never that they were scared or not ready to come in, right? So the way you meet, you keep the children so comfortable. So that's adoring, and I'm really happy to have you and talk about this, your practice, and bring you to my show. So
thank you, Naga. Thank you. Happy to be here. I remember your kids fondly, and I am very happy to see this side of you, not as a worried parent, but as a on a podcast and outside the hospital setting.
yes.
So, thank you.
Thank you. So I'll quickly start with the pediatric rheumatology. Is a practice. I think when I also start, after meeting you only, because I got to know about rheumatology as a practice, and and then I was also trying to understand, okay, what is it all about, and then through that journey of meeting you, I know, okay, that is practice that exists, and beyond, which is, you've been part of the journey of bringing pediatric rheumatology in India. So for the last 10 years you've been practicing. Talk to me, probably share your experience and journey into this, doctor. While pediatric has been very common, I know a lot of specialization in pediatric, but rheumatology is not very known from a practice standpoint. So
yeah, so I was exposed to pediatric rheumatology as a resident when I was doing my DNB pediatrics in Jaslok Hospital in Bombay. I had the privilege of training under some excellent clinicians there, and one of them was Dr. Raju Kupchandani, who actually trained in London, at maybe in a mid-career, and then he came back and he started the pediatric rheumatology outpatient clinic in Jaslok Hospital. So we saw some very fascinating cases, and that was what actually piqued my interest over there. But subsequently, it was after finishing post graduation, it was about finding a job and about getting experience as a consultant. And I, at that time, my opportunities were in the neonatal intensive care unit. So there was a break from pediatric rheumatology, and it was about training as a neonatologist, as a general pediatrician. And then when we moved back to Bangalore in about 2008, 4 years after I finished my pediatrics, I was always keen to come back to general pediatrics. And then from 2012 onwards, I renewed my interest in pediatric rheumatology. by attending online courses, and also my professor Dr. Khubchandani conducted refresher courses in Mumbai. So at that time, fellowships were few and far between, and I had an infant whom I could not leave and move to other cities. And I came across this online course conducted by Pediatric Rheumatology European Society and EULAR, European Union Alliance for Rheumatologists in Europe. So this was pre-COVID days when online courses were not the norm actually. In 2016, I had the opportunity to do that for it was a year-long course, and there was an online exam at the end of it. So that helped in improving my knowledge and the clinical experience we were seeing in the government hospital in Indira Gandhi Institute of Child Health in Bangalore. So I have been fortunate to be associated with that institute for the last 10 years, more than a decade now. And I should thank my mentors both in Bombay and in Bangalore for allowing me to pursue this subspecialty interest. And subsequently, as the pediatric practice grew, I was also pursuing pediatric rheumatology side by side. And that's how it's been in this last decade. So, practice at a corporate hospital where we do our routine pediatrics, and also a pediatric rheumatology clinic. And the association with Indira Gandhi Institute continues, and we are happy to teach postgraduates over there. We are happy to treat the patients who would not get this kind of care anywhere else in the state for a very, very, no, it's literally free of cost. And we also are able to do our presentations and publications of these rare cases, which we see in this institute. I think I have received more than what I have given from that institute, and I hope to continue my association and do more in return in the coming decade. So that's how it's been. And the pediatric rheumatology as a subspecialty was fairly nascent in the in between 2000 and 2010 in India. But now there has been immense awareness. There is a lot of growth in this field. More and more youngsters, after passing out from pediatrics, are choosing pediatric rheumatology as a subspecialty, and there's now a DM course, a 3-year training course in pediatric rheumatology after pediatrics in a couple of centers in the country, and another 2-3 centers have 2-year fellowship courses. So that way we are seeing very well trained students who are coming out, and we have a lot to learn from them too. So I would say the founding fathers were Dr. Raju Kupchandani, Dr. Sujata Sani in Delhi, Dr. Amita Agarwal, who is a senior adult rheumatologist in SGPGI Lucknow. So these have been our idols or role models whom we look up to. I would say I'm the mid tier, and now the younger generation is also coming up very, very rapidly, and they are very smart. They're very well read, up to date, and they have the benefit of being trained with structured curriculum and courses, which were not there when I passed out from pediatrics. So, but that way, that's how it is. We do our bit, we contribute, and we hope to hand over the reins maybe in another decade from now to the next generation, who are very capable, no doubt.
Wow.
For me, it has personally been a very fulfilling and very satisfying journey in this pediatric rheumatology, because like I said, there is lack of awareness. These children don't get the care that they should be
Right.
getting timely, and it leads to deformities, and untreated disease can have like devastating complications. So
Yeah.
that way, those few patients whom I have seen, I hope that I always have made a difference in their lives. And it's a teamwork. No one person can do everything together. I'm thankful to my colleagues in the hospitals where I have worked. Sick children need pediatric intensive care. They need the round the clock care by the team of junior residents who are there on duty, the nurses, the physiotherapists, the paramedical staff. I have a physician assistant now who is actually an Ayurvedic doctor, but who has picked up the ropes very well in pediatric rheumatology. So that way, it's a team, and we are only one cog in the wheel.
Yeah. No, I think, wow, I think listening to you, I can listen for another hour about your experience and the contributions you've been doing on this practice, right? So, so happy to hear from you in this conversation. So, thank you so much, Dr. Jyothi, for giving a journey of your journey of moving into rheumatology, right? I think you've been in you've been in the neonatology as well. I think probably with NICU and looking at the newborns. So that would have been a very challenging place to be. While probably pediatric rheumatology is even more nascent when you started, and probably that was interesting. But how talk to me about the neonatology? I mean, how do you probably that gave you interest in terms of moving into looking at a lot of complications and the newborn complications and even probably the inflammations, and I
Yeah,
mean, is that an interest then you developed to move into?
yeah, neonatology is actually the most well-known subspecialty in pediatrics, the
Yes,
earliest super specialty, and the it's like it's always been there, and we have these neonatal ICUs too, which
right,
are needed for newborn care, for preterm babies, for low birth weight babies, for babies who are born with complications,
right,
and it is a very interesting field, and also a very very well developed specialty. And when I was in Mumbai after my pediatrics, my husband was still finishing his super specialty because his was a longer course than mine. He's a neurosurgeon. And so I was working in the neonatal ICU in a place in Vadia Hospital. After working for a year in pediatrics, Vadia Hospital is a trust hospital, which is very, very well run, well oiled, and it runs like a well oiled machine, and very huge numbers of patients. So then there's a sister concern of Vadia Hospital called Naurozji Vadia Hospital, which has a 30 bedded neonatal ICU, where I was working under the main neonatologist over there, as almost like as a lecturer and as an in charge for that unit. And we used to take care of the preterm babies, the low birth weight babies, the sick babies who needed ventilatory care, and that was a very good experience for me in neonatology. And subsequently, when I moved to Bangalore, I took a brief maternity break. And then when I got back, the place where I was living, the Manipal Hospital, Old Airport Road, was the closest hospital, which was well established. And it was a natural progression to join the neonatal ICU over there with stalwarts such as Dr. Karthik Nagesh, Dr. Arvind Chenoy, who are themselves big names in neonatology in our country. And under them, it was again a very good experience to work. It was difficult, no doubt. We had 8 a.m. to 8 p.m. shifts, or 8 p.m. to 8 a.m. shifts.
wow,
And balancing that with an infant son was possible only with family support. My in laws were with us, and my husband pitched in. And somehow I did work there for more than a year. But then I was always clear that pediatrics was my first love. I did not want to continue being only in neonatal ICU
yes,
because burnout rates are higher, and I am more of a maybe somebody who they likes to solve difficult cases, who always fond of murder mysteries. So our rheumatology is something like where it's a clinician who has to arrive at a diagnosis through history taking, through examining the patient.
yeah.
And while neonatology has its own advantages and satisfying results, it is
So
I
there are
for me
more doctors at least now it is evolved. NICU is equipped with all the hospitals are equipped with NICU and actually able to handle the newborn children or with
yeah,
complications or premature. So
yeah.
yeah, I think maybe the rheumatology practice drawn or wanted Dr. Jyothi.
So I was Yeah, when I recently met Dr. Arvind Shenoy, he said you defected from neonatology to pediatric rheumatology, and I said, yeah, maybe you could say that, but I think I always wanted to come back here, and I've just been fortunate to do what I've been able to do all these years. So it's a
Yeah.
learning curve, it's a journey, and then so it's like along with general pediatrics, I'm a pediatrician first by heart,
Yes.
and a pediatric rheumatologist. Maybe I would say that I'm still a student in pediatric rheumatology.
Yeah, you're so humble, doctor. I think, yeah, we can see that when you say that pediatric is your first love. So because definitely the love and the passion for the children, it is very evident when any parent brings their children to your your for consulting to you, right? So which is the important aspect any parent would love to have, from a doctor who is more like a family, and you can talk to and ask any questions, and then you are able to answer that, without any hesitation, and spend that time. It's not like always that the consultant is 30 minutes and I have the next patient. So I mean, I mean, that's some people I know. Sometimes I also feel that it's like a connection. You try to you meet right people at the right time. So when I moved to India, and then I was looking for a pediatrician for uh, my son who was newly born, and then my daughter, I think I landed and met you. So I think I know sometimes it's the way universe brings us to the right person. I feel that way. So
Very
I'm
true.
so
Yeah.
thankful, for the Almighty, and also, thankful to you to being part of my journey and witness.
Thank you.
And
Those are very kind words, and we do what we can. But when we treat it as a calling, as a not just as a profession,
yeah,
and then it is something that I think we do develop a connection with some families, which continues long after
yes,
they're we
yeah, yeah. No, I
once.
think we still. I mean, I still remember you and my wife and my kids, right? So, I'm happy that you made an impact. So, talking about so rheumatology, and I'll go a step back from a pediatric. And you've been doing pediatric a consultation and pediatric practicing pediatrics for a long time. So from how what have you seen as a common uh, pattern in terms of the children, right? Let's say when the diagnosis between a general pain versus moving into more of a rheumatologic or probably more of arthritis, it's something which not many parents would be able to differentiate, right? Let's say if it's a normal pain, because you don't think that it would be the inflammation would flare up into going into more of a, sometimes it is a juvenile arthritis, or
Yeah.
it could be a pre arthritic condition, or just an inflammation, but it is actually tending towards that, right? So the and I mean, how what is the percentage of children where in your practice you have seen where they thought it's probably a normal pain, and probably they're going through for a week, and then it becomes, or probably it moves into the
Yeah.
stage of an arthritic condition or autoimmune condition.
Correct. Yeah, that's a good question because most of the cases that we see are not always rheumatology or autoimmune. And I think that's why my general pediatric basis kind of grounds me over there because we see children coming with acute pain, something which is very short lasting, just
Mm.
about a week or 10 days. That is not something that we would think of autoimmune immediately. So there are different causes for pain, there are different causes for joint swelling, and we need to approach it as a clinician and see, is it acute, is it subacute, is it chronic, is it infectious, is it something due to inflammation or non-inflammatory, it could be just a trauma or a mechanical cause. And so there are a lot of causes, so we approach it with a detailed history taking, examining the child in detail, and doing some relevant tests which help us to come to a diagnosis. So most of the problems we see in pediatrics are something acute trauma or infection related or
Right,
just
right.
following an infection, like a child may have had a viral cold,
Mm.
cough, fever, and within 2 3 weeks later develop some knee joint pain or swelling. That is not immediately what we call JIA or juvenile idiopathic arthritis. That is mostly just a post viral reactive arthritis. which we expect that will settle down in couple of weeks with just ibuprofen or paracetamol, and we just have to keep a close watch and follow up this child. So there may be something, a child may come with just few hours of severe pain and not even able to move the limb. And that becomes an emergency because that may indicate an infection in a joint, which has to be treated immediately with IV antibiotics. We need to do a simple joint aspiration, test the fluid for infection, and start off on antibiotics, and get the diagnosis of septic arthritis immediately. That should not be missed. So it can be something, and some children come with months of history or of pain and swelling which has not been diagnosed correctly. They would have met many doctors. Sometimes our population ends up going to orthopedicians for pain and swelling, where they think of trauma or other causes, and then child is not referred to rheumatologist in time because many are not aware of this specialty, and by that time some damage has already been done. So there is a whole spectrum which we see, and not all are autoimmune, not all are inflammatory. That's how we need to clearly differentiate, and it is by a detailed history, by a proper examination, and that's why this takes time. It takes about, we need to give about 30 minutes for the first consultation, 30 to 40 minutes for the patient, and to get our, what we are thinking of. Tests are not really randomly used. Investigations are very judiciously prescribed depending on what we are suspecting, and that is how we arrive at a diagnosis. And any child with more than 6 weeks of pain or swelling in the joint, and all other causes having been ruled out, and if the onset is before 16 years of age, that is called juvenile idiopathic arthritis. Juvenile because it starts in a child, idiopathic because the cause is not known, it's a combination of genetic and environmental factors, and arthritis means pain and swelling in the joint. So that is JIA, but that is only a diagnosis of exclusion. Everything else needs to be ruled out before that. So that way, in pediatrics, as such, most of the times we see patients coming with just a simple pain, or sometimes parents are worried child is limping, and sometimes they may not even have noticed. So we have to we sometimes ask and then get the correct history and point them towards the right direction.
Yeah, absolutely. I think you made a very valid point. I think that the misdiagnosis or probably delayed diagnosis also has actually a major concern. Especially, you said, parents tend to take to orthopedician, especially that's very natural for every one of us to believe that anything related to joints and bones, or probably
Right.
go to an ortho, and that's been a condition, right? So
Correct.
it's difficult to understand and probably look at rheumatology and try to get the diagnosis. But as you say, yeah, maybe there is no trauma, because sometimes the children is not able to even say that
Yeah.
why the pain is. So because
Right.
they've not really heard, or probably they didn't get into
Yeah.
any kind of an impact which is actually causing the pain. So it is difficult for them to say.
Yeah.
So the parents' natural tendency is to go towards,
Yeah.
if there's a joint pain, then go to ortho to
Yeah.
solve it there
Or
as well.
if
Yeah.
correct. So the younger children may present with a painless limp actually,
Hmm.
and some children may present only with inflammation in the eyes, which
Okay.
is not picked up. And if any child with juvenile idiopathic arthritis needs to be screened for inflammation in the eyes, because it may be a silent inflammation. And
Hmm.
only when the ophthalmologist checks, we know that there is something happening in the eye too. And we need to give treatment for that also. Otherwise, it may lead to serious complications in the eyes. So that is something that we screen every child for. So this, and we see the others way also. The children who have eye complaints go to the ophthalmologist, and then they are diagnosed to have inflammation in the eye called uveitis, and then they are referred to us for treatment. They may not have joint symptoms, or they may have, but the rheumatologist needs to tailor the treatment for the inflammation in the eyes. So these children also need follow up with both ophthalmologists and rheumatologists. So that way, rheumatological conditions can affect any organ, but
Any
most
organ.
common being skin, eyes, and the joints. For JIA, at least it's the eyes. But there
Okay.
are other autoimmune diseases which can affect multiple organs,
Hmm.
and that is when we need to, be very careful about the organ system affected. We need to look for other organs, even though child may not have symptoms, and then treat accordingly.
Right. I think when I was trying to understand, especially having two kids and being a parent of two younger children and growing up, a lot of things which you are actually trying to understand, talking to the doctor or trying to read about it. But sometimes I also strongly believe that more information you gather, it is more worrying.
Yeah,
So it's better to let the right people do that job. So
correct.
more than you just trying to read too much about it. But
Yeah,
understanding of a situation is important. Like what is happening. Okay,
yeah,
whether it's the right time to take the doctor. Can we just wait for a day or two? So those are things which a parent can try to
yeah,
wait instead of just
yeah.
immediately going and going to a doctor. But yes, as you say, I think when it
So
when
we do in the clinic also. I think whether it's a simple fever or whether it's a some other illness, we spend time counseling the parents. Why this has happened?
Hmm,
What is the treatment? What tests are needed, if at all, and what they need to know. What are the red flag signs they should look out for? When they need to come back? When should they bring the child to hospital? And now there's an explosion of information, right? So everything, not just Google, there's ChatGPT,
yes,
there's so many AI platforms where anything and everything will be available at the click of a button.
yes,
And like you rightly said, overexposure and over Googling can actually lead to a lot of
anxiety.
concern and false panic, among a sense of false panic or reassurance sometimes amongst parents. So we see that routinely nowadays. So
Hmm,
they would have already consulted a family physician, somebody in the family is a doctor, given some medication, or an online consultation is done, or they themselves read up and try to see what is to be done. And then they come back after 3 or 4 days with some tests already done. So most of the times we are just dousing the fire and telling them that no, there's nothing happening here, don't panic. And sometimes it can lead to a some symptoms being masked. If some antibiotics have already been given for an infection, we don't know what is going on. So those are the disadvantages in the times that we practice today. We have to educate parents, and we have to communicate effectively, spend time for each consultation, because the medications that we give in pediatrics are very few, and it is more about education and communication, and telling
right.
parents when they need to come, what are the warning signs they should look out for.
Yeah, I think I say, I think both ways we have to if you have to weigh the pros and cons, right? I think from medical and pharmaceuticals industry standpoint, the focus is on trying to get into the antibiotics or as soon as possible to actually suppress the pain so fast. But then the consequences of that, I think I was when this rheumatology also, the I mean, especially the
Anti-inflammatory.
anti-immunization. I know the steroid use of steroids has been so prevalent from in terms from the last earlier
Yeah,
before, and then now the biologics have come into
yeah,
play, is actually helping
yeah, yeah.
the industry a lot. So maybe please bring awareness on that, Dr. Jyothi.
Yeah, so glucocorticoids or steroids are actually the first line of anti-inflammatory medications, one of the first line, along with painkillers like ibuprofen, naproxen for arthritis patients. We sometimes need to use steroids also, not for all arthritis cases, but in other autoimmune conditions and some types of arthritis, we do need to use steroids as a short course just for reducing the inflammation and for giving some relief to the child from the symptoms. But along with starting steroids, we also start on other medicines called disease modifying anti-rheumatic drugs, which are medications which are not steroids, which
Mm.
can be continued for a long time safely, although the child needs to be monitored regularly. And these are the medicines which will help in reducing the inflammation over a point of time. But because these medicines take some time to act, we do need a short course of steroids sometimes in the first few weeks of illness to control the inflammation and the symptoms. In certain other autoimmune conditions like SLE, lupus, juvenile dermatomyositis, steroids are actually the life saving drugs which are needed So we have to start those, at the same time add on the disease modifying anti-rheumatic drugs. And now, of course, the biologics are here in a big way from the last decade, which have been game changers, and which are actually which have reduced our need for dependence on steroids a lot. And the biologics actually help to put the disease in remission. That means we are actually able to control all the symptoms. The child is doing well, the lab tests are normal, there's no signs of disease activity. The flip side of biologics is, because they are very they reduce the immune system, they kind of suppress the immune system a lot. The side effects are more, as in the child is prone for infections, because the immune system is not able to actually recognize the infectious agent also, right? So we need to monitor carefully for infections, both the usual and the unusual infections. We need to monitor these children for these infections. We need to make sure they are vaccinated properly before
Right.
we give the use the biologics. So they have to be used and by a trained rheumatologist with proper monitoring. And even adult rheumatologists also don't see the don't have the issues that we have so much in pediatrics, because pediatrics is a period of rapid growth. We need to monitor the child's growth.
Yes,
We
because
need to monitor the child's immunization status, and which is not so much in the adult, although some few vaccines are used even in adults on biologics. We need to we need to actually treat the family, not just the child, because the child is going to school, the parents have a lot of issues to handle with the child's illness. There may be psychological issues. The child will need physiotherapy along with the medications. So it's a whole team at work, and they may need to meet other specialists, like I said, the eye doctor or the kidney doctor. And we have to act as an anchor person for all these consultations that are happening, and make sure that everything is going hand in hand. So biologics have been game changers. They are expensive drugs. Some are not available in India yet, which are available in other countries. For example, there's a drug called Anakinra, which is a wonderful drug, especially when we are not sure if you're dealing with infection or autoimmune cause. And but it's not yet freely available and prohibitively expensive for many of our patients. So, over last few years, as patents of some original biologic molecules have expired, there have been biosimilars which have come in. That means which are the same drug manufactured by different companies, but using the same technology. But there's still something called the original molecule, and there are copies called biosimilars. So the biosimilars have played a huge role in reducing the cost of these medications, so much so that even in our government hospital setting, we are able to get patients to afford these
afford
medicines,
these medicines.
or to get some pharma support or government funding, as these are some of these are very rare diseases, and the government does help in getting funds for us to prescribe these medicines. Pharma played a big role in helping us to treat these underprivileged children. Wherever possible, pharma pitches in, and with something like, if the child is able to, family is able to afford one dose, they give one dose free of cost. Unfortunately, very well in India, we don't have the social security or the free thing, or
Right.
unlike the UK, or the
US.
robust insurance that is there in US. So a large part of our population, and even in private sector, those who can afford to come to corporate hospitals, it's all privately funded. So we have to help out these families in being able to procure this medication. And that's the pitfalls of biologics: the cost and the side effects, where they need to be monitored for infections. But the advantages are that we are able to reduce the steroid dosage much quickly, prevent the side effects of steroids, we are able to stop steroids much earlier, and we are able to get them into targeted remission, and where they're almost disease free and able to continue with their schooling, their activities, everything.
So that's, I mean, That's heartwarming to hear, right? Because arthritis as a condition difficult to handle from an adult, for an adult, but children who are actually actively playing and they want to go out and play and looking at other children, so that is it's a stressful years
Yeah,
for them if they actually been diagnosed with
yeah,
arthritis or juvenile arthritis. It's
yeah.
definitely going to be a helpful, but again, it has to be prescribed and monitored by the right practice and the doctor.
That's very true. So for juvenile arthritis, luckily we still have our first line drugs like methotrexate, which is very simple and which is the first line and that works in most cases. And then we have some other these disease modifying anti-rheumatic drugs, synthetic drugs, which are also effective and we are able to, most of the patients are able to afford them and we are able to stop steroids. Biologics are like the next line, but there are cases where we straight away use biologics if we feel they are indicated. Biologics are more needed for the other more dreaded autoimmune diseases like lupus, juvenile dermatomyositis. Then we have something like systemic sclerosis, connective tissue diseases, what we call, and vasculitis. So in all these conditions, we do need to use biologics more earlier.
So
But
in
we
all
have
these will start with more of an inflammation or it starts with an just a infection, right? So
so it comes,
it
yeah. Oh, sorry. What I was saying was that these autoimmune diseases occur. We don't know exactly why, but when in a susceptible host with a genetic predisposition,
hmm,
if there is some trigger like a viral infection or a
right,
bacterial infection, then these autoimmune diseases can get triggered off. Okay, so it is something like now the same virus may affect many children, but not everybody reacts the same way.
just the same way.
So it's a combination of the genetics, the environment, and the host. So interplay between these three factors is what causes the autoimmune disease. And there are autoantibodies which we see in some conditions, but in some there are no autoantibodies in the blood tests which are seen. And there are two types of immune system: the innate immune system and the adaptive immune system. So the innate is the older one, the adaptive one is the phylogenetically the newer one, the T cells and the B cells.
Yeah.
And there is also another condition now that we see, autoinflammatory diseases, which are diseases of the innate immune system. And autoimmune are diseases of the adaptive immune system. So it's very fascinating and it is technical, but there's a lot of rapid development which is happening, especially with autoinflammatory diseases in the last 5 to 10 years. And so much so that every few months, the list of autoinflammatory diseases is like just being, new diseases are being added on. So the future will be where we do genetic testing and we see what the genetics
And
shows,
competition.
and that will kind of will be able to predict the course of the disease and the treatment that child needs based on that genomics. We are already doing a lot of genetic testing and identifying newer mutations and newer diseases. But that is more for autoinflammatory. For autoimmune, it's more standard where we do the blood test for the autoantibodies and then we diagnose the disease based on that. So that's how the immune system, there has to be a fine balance between recognizing the foreign antigen, fighting that foreign virus or bacteria which attacks our body, and immune tolerance. Immune tolerance is where the immune system doesn't attack the host or the own body tissues. When this balance is disturbed for some reason, that's when the autoimmune diseases start. Why that happens, it's
Yeah.
still not clear. Yeah.
I think yeah, I think even the inflammation or even the infections, there are multiple causes. I think. Do you see this rise in India too? I mean, in terms of allergies and trying to how much of the cases you have seen? Probably 1 in 10 children you see that this is a common inflammation allergy
Yeah.
or
Very common. I think one in five,
oh,
I would say,
that's all.
because they may come as, yeah, cold cough fever, but we'll have to actually kind of take a detailed history to see if it's allergy, if it's infection. Viral infections can trigger allergies. So it's the rising air pollution, urbanization, the lack of green spaces, the family history where there can be allergies, asthma in the family members, and the I think the corruption of or adulteration of food, air, water, everything. So all this contributes. Allergy used to be less earlier, although it was always there. But I think with affluent population, less exposure to what we call the unhygienic lifestyle in the early childhood predisposes more to allergies. So earlier children in rural areas used to always be playing in
Yes.
farms in muddy everything, and somehow allergies are lesser over there. In urban areas it's a paradox where we try to bring up the child in clean sterile environments as far as possible, and then maybe they become more prone to allergens. But we are seeing a lot of allergies, and when it's just of the nose, we call it allergic rhinitis. When it's in the air passage or the lungs or the bronchi, we call it
Yeah.
as asthma. And food allergies and skin allergies also are becoming more common. So we do definitely see a lot of these, and again, parents or families try to resort to alternative medicine for allergies because they feel inhaled steroids are harmful, and we have to counsel them and see which child will benefit from that, because that is evidence based
Right.
treatment.
Yeah, I think food allergy is one more topic to discuss, but again, asthma is very common one, I think, especially bronchitis, and you said uh, anything which starts with more of a cold cough, but it goes continuous for a long time. So that is very, very common, I would say. Yes, doctor. So you were mentioning that in India too, you're seeing that the allergy pandemic, or it is on the rise, and I know you were mentioning that 1 in 5 patients you see is in that spectrum. So please give some insight into what do you think is the right why the rise is happening in India too, but because I know in the Western countries there is a lot of food allergies, and especially I see that 1 in 10 children are actually, or even the adult, having asthma. So in India too, you see that this in rise. So maybe what are the difference now? Do you see the rise in the last 10 years, or it's in the very recent?
So I think it's always been there, but it's been increasing with urbanization, with lot of pollution, more and more vehicles on the streets, less green space, and children being at home, more sedentary lifestyles, hardly playing outdoors, eating more of junk food. So all these are also the reasons for allergies to increase.
I think maybe the westernization of the food. Do you see that children are when you talked about junk food? That's a very very bigger concern these days in terms of children not eating. So that's also one of the pattern. Do you see? So what is your recommendation from uh, you know for the young children to be more immune, maybe from your practice and what you have seen in the last 10 years, and how you see the change. So maybe what are your recommendations for parents to make sure that the kids grow up immune, right? Maybe give some.
So starting with right from actually even the before birth, mother should be aware about how the diet that they consume in pregnancy can affect the baby's health. They
Hmm.
should have a healthy lifestyle, avoid smoking, uh, alcohol, and also go have maintain a healthy weight in pregnancy, not be overweight or underweight. Also, once after birth, baby should be breastfed. So, breastfeeding helps a lot in minimizing allergies to large extent food allergies. Of course, where needed, formula milk will have to be used, but if not, they should not be under the misconception that formula milk is needed for baby's weight gain. That is something that we try to emphasize to mothers. Breastfeeding has a lot of benefits, one of them being minimizing the risk of allergies. And subsequently, also, they should start the correct weaning foods. The complementary diet, what is started after 6 months, should be as prescribed by the pediatrician. and we ask them to start the dairy milk, cow milk, animal milk, or any other dairy milk after 1 year preferably, and eggs and meat also preferably after 10 months to 1 year. So, and if
Okay.
at all, food should be introduced gradually. And if there's any rashes or any signs of allergy noted, such as diarrhea, rashes, or not gaining weight, vomiting, then they'll have to go slower, avoid the offending agent, and then reintroduce it slowly. And later years, as they grow and they go to preschool, or when they are outdoors playing, mingling with other children, they will be prone for viral infections. So it's important to recognize those, avoid antibiotics, and also differentiate between viral infection or allergy,
Allergy.
then treat accordingly. So, if doctors prescribe the medications for a respiratory allergy, especially asthma, which is inhalers, parents should follow the prescription. And many times we have to emphasize to parents, and despite that, they stop it before the prescribed course is over, thinking that inhalers are harmful or children may get addicted to the same. And then we have to, start all over again. So, following that medication for the prescribed time does help. Many children, 60 to 70% of children, outgrow the childhood allergies and asthma by maybe 7 to 8 years of age. But we can't say if there's a strong family history, if there is a very early onset of wheeze, if severe episodes, then these children may continue even later on. But usually, the incidence of the episodes decrease as they gain
Decrease.
some immunity towards viral infections.
But
Maintaining a hygienic environment, dust free, avoiding smoking at home, and
mm,
exposure to other smoke such as incense sticks, agarbatti smoke, or some
right, right.
cooking smoke. Of course, less in urban areas. In rural areas, it used to be there earlier, the chulas and all that is less. Mosquito coils, those are something that can trigger. And I find here in the place where I practice, a lot of gated communities, there are lots of sand pit, and even in
Yeah.
preschool sometimes there's sand pit, and that may cause dust exposure. So I'm minimizing clutter in the room, avoiding keeping a lot of soft toys or fleece blankets and carpets. All these gather dust and they are difficult to vacuum. I know in Western countries it's cold and usually the floor is carpeted,
Yes.
wall to wall and everything. But it's not really necessary in tropical countries. And
Yes.
sometimes, even if it is in cold areas, then it should be maintained dust free. That's all.
Well, true. I think there is a change happening. Even here, I see that not every floor is carpeted. So there is places where there is actually, I mean, but people are moving away from, bedrooms being carpeted because it's difficult to vacuum after a while. And yeah, and in India, I mean, when you say that, um, especially the point what you talked about the agarbattis and also the mosquito coils and even the scented candles.
True.
So,
Very
so
true.
people are not aware of the health hazards which those
Yeah.
uh, I mean that causes to the children, especially agarbattis and mosquito coils. We tend to go by 20 years old, same logic that it's actually good, but then today's world, we don't even know the ingredients which is put into it, so it may be
Yeah.
actually harmful to the
Right.
children.
So we can
So
avoid certain things which are under our control. That's what I
yeah,
tell parents. Some things are not under our control. Outside the house, dust
environment, yes,
pollution, the vehicular smoke, the air
yeah.
pollutants, those are not under our control. The climate change, the weather, seasonal changes. So then we will have to treat with medications. But till the child is able to outgrow. And of course, now there is a shift towards sublingual immunotherapy, or more allergy testing and giving specific targeted therapy earlier than later. Usually, earlier it used to be the difficult asthma cases whom we would refer for allergy testing, because
Mm,
most of the time it comes up to be dust mite, and how much
yeah.
can you do about that? So, but
Yeah,
nowadays, yeah, we don't want children to be on inhaled corticosteroids for a long time. We do
for a long
refer
time.
them for allergy testing and sublingual immunotherapy. So that is something that has taken off, and we have a lot of pediatricians who have specialized in allergy and asthma
Sublingual.
and
Okay.
allergy testing, and they are we refer the parents to the family to those doctors who can guide the parents for sublingual immunotherapy following allergy testing.
So when you say allergy testing, I just want to throw some light, right? Maybe it's more technical, but I'm trying to get understanding from you. So anything which your system is actually not able to take, it's a foreign and you're interrupted, right? So one is that when your system is actually developing, so immunoglobulin, um, it's I mean, your body produces immunoglobulin, and then the testing what you do is to actually check the IgG, or I mean, or the
IgE.
strict testing
Yeah,
IgE
allergen specific IgE levels are checked. There are both blood tests available and also skin patch tests, which are done,
in patch test.
skin prick testing,
Hmm.
SPT they call it. These are done by, see, there are lots of labs offering these tests, but I prefer to refer to a pediatrician who is trained in testing and interpreting these tests.
Right,
There
right.
may
That's
be
true.
a comprehensive panel of blood tests which is done by labs, but then if they're not interpreted correctly, then again we are. So sometimes it may show
Hmm.
allergy to certain foods, but the child has been tolerating those foods. So then it doesn't make sense to stop. Child may have visible symptoms with milk or wheat, and it may not show up in the test. If it does, if it correlates, that's fine. But if it
Yes.
doesn't, we still have to go by trial and error and what the child actually,
And
should
probably an
tolerate.
elimination diet to check, and then you get back to that diet and see if it is actually giving you that allergy. And I think there is a
That's
difference
correct.
between allergic reaction versus the having that allergy. So I mean, that is what, for example, the IgE versus IgG. So what is the severity of that is something which parents should be at least aware of.
Correct.
And and what I understood from a research which is done from, I think, one of the research scientist, medical scientist from Mysore. So the Europe Fall research, which was done from for different countries. So India was participated in that, and they took a lot of samples across the country. And
Mm-hmm.
what was coming is, it's not that if the IgE is high, it doesn't mean that you have an allergy. Because a lot of people have been eating those, even adult or children as eating those foods, but it
Yeah.
was the IgE levels are high, but not really they have an allergic reaction, or something which is common from an Indian. Maybe which what are the causes for Indians and the body to actually not produce that allergic reaction. But there was a research which was presented in recently. So as you say,
I
you're
think we'll have to just individualize.
yeah,
Some allergy specialists prefer blood tests, but usually the ones who are trained prefer the skin prick test, and they have to
in
interpret
test,
it
yeah.
correctly and then
Yeah,
decide and counsel the parents accordingly.
exactly. I think that is true. So it's always not to do test yourself and try to interpret that you have an allergy and stop all the food. It is going to be a terrible
Yeah.
repercussions for the children.
Because it's available in a lot of labs these days, parents want to get it done sometimes on their own, but then
Mm,
interpreting it and deciding what to eliminate and what to continue becomes an issue. So I would
correct.
refer them, those children who have difficult to control allergies, yes, it does really matter, but majority of them we can just help the children by treating during the seasonal flares with either in the corticosteroid nasal sprays, antihistaminics, and the
Yes.
budesonide inhaler if the child has more of wheeze and asthma. So we do counsel parents about what, why the child needs these and how it should be given, and how long they should continue it, what they should watch out for, and when they should bring the child to hospital. So
So this becomes these allergy again. Thinking of this, you don't want your kid to stay indoor. You want them to go and play outdoor in the mud and probably get the immunity. But you have to really be cautious in terms of when uh, how much of the dust exposure is there, and whether they are reacting to it, and then be cognizant of that, and work through the
So it's actually a child is indoors most of the time, and 8 to 10 hours child is in the bedroom during night time, and that is when something in that environment can lead to a flare. So we do want children to be play outdoors, pursue their sport of their choice, and they should be able to do everything that they want to, not hampered by allergies or any other illness for that matter. So
You've
that's
seen any extreme cases like that, like a children has probably been very controlled or probably within the indoors, and they've not really exposed, and the allergy reaction is so high. Even I mean, at least in your practice, in which is you.
So yeah, they we do see parents actually restricting children
Hmm.
for fear of allergies, thinking that if the child is exposed to cold air or breeze, will catch a cold and cough, or if they go and play outdoors, they get cold. But and we'll have to counsel them that no, your child has to go out and play, and this is the treatment that is needed to keep him fit, if any treatment is needed. And
Hmm.
moreover, it is more to do with the indoor environment in the house and in the bedroom especially. So we tell them what all to take care of for the indoor pollution,
Yeah,
the indoor
exactly.
triggers. And because house dust mite is a very this thing, a very very common treatment.
Common.
Right?
Yes.
So that's the thing. And also the other issue is that the outdoor sports, like if a child wants to play football and it's in a ground, then there is exposure to some to dust. So we'll have to, and if the child is passionate, we don't
Stop
want to
them.
stop them or make them change the sport. So then that's when we offer the treatment. Just taking the inhaler before playing will kind of give him the stamina and the endurance. So these are something that we counsel. And outdoors, we can at the most when they're traveling in school bus exposed to dust, they can wear a mask. But it's not practical for children to be in masks the whole day, and we don't want that either. But we have very good treatment available for allergies. There are very good experts, so we are able to refer them if needed. There are some children who are very difficult to control asthma,
Hmm.
whom I have seen, and from young age, despite all medications, it's very difficult to control. And in these children, yes, their growth is hampered. The height
Right.
doesn't increase as much as it should. They don't reach their growth potential, and they need some specialized treatment beyond inhalers. And there are monoclonal antibodies which are available. And this in these children, that allergy testing and the sublingual immunotherapy started early makes a big difference.
When you say sublingual immunotherapy, that maybe throw some light on that, right? So it is more to improve the immunity for the children, or
No,
especially
it's
when it's
a process of desensitization actually,
okay.
where whatever allergen the child is allergic to is given in small amounts
Hmm.
as a powder or a medicine below the tongue, which kind of makes over a process of time, it makes the child immune to that allergen. Desensitization therapy.
Okay.
I am not the expert. I don't practice immunotherapy, but I do refer to the doctors who will prescribe that. But this is the
The
basis behind
base.
it.
Okay.
Yeah.
Right.
So many parents follow alternative therapies like homeopathy.
Hmm.
Maybe it is the same thing. We don't know about the alternative pathies, but it is, maybe similar. So it is just that in other homeopathy or Ayurveda, we don't know if these medicines contain any steroids or other substances. But in our, the modern medicine, these allergy testing is done, and based on what the child is allergic to, the either elimination diet or immunotherapy or both is offered to the family.
Got it. Thanks, doctor. With I think that's there is a lot to be aware of, but again, as you said, don't do don't self-medicate, or even try to understand yourself with the interpretation. Even if there is a test results, the right doctor interpretation is very important for you to continue the next course of treatment. So, which is very true.
Parent education counseling is very important. It takes a lot of time in the clinic, and we have a team, a nurse and assistant, physician assistant, who explain how to use the inhalers and when to use which one, and
Hmm.
how what they should watch out for, and what to do in case suddenly there is a bout of wheezing in the night, when they should come. So all these instructions have to be given to parents.
I think the 4A. I think what I've read in this there is this 4A disorders. which is prevalence. It's about autism, ADHD, asthma, and allergies. So 1 out of 4 adults, or even 1 out of 5 children, is have seasonic allergies, and it leads to any of this, right? But moving from away from allergy and asthma, do you see that ADHD is also
Yeah.
or autism spectrum is also in the increasing in India too? In your practice, you have seen or
Yeah, very, very much, very much. Yeah, over the last 10 years, there has been a substantial increase, and that is both due to maybe a true increase in the prevalence, and also due to better and earlier pickups of these conditions because of more awareness amongst parents, amongst doctors, and the
Mm,
therapies that
mm,
are available. So it's both due to that. I think it's the prevalence or incidence may have increased because of so many things. Like again, the diet is one thing, lifestyle, the increased screen time,
yeah,
decreased interaction with peers and with parents. There is a lot of other maybe exposure to some toxins in the environment which we are unaware of. We don't know the exact cause for autism and ADHD, but we know that it's a not one single cause, right? There are some genetic factors which can lead to autism. It's known, but there are most of the times it is not one single genetic
mm,
cause. It is more of environmental plus genetic plus other unknown causes. So what is important is to pick up these early and to start early intervention. Sometimes parents are they have some clue or they are some doubts, they come to us and ask us, is my child's speech and development on track, or they have noticed some warning signs. But majority of the times it is we who notice these in the clinic and then begin to probe, and then the parents have to go back and think whether child is doing these or not doing these. Then we give them questionnaire which they can observe the child's developmental milestones at home, and then get back to us to see if there are high risk factors, any red flag signs.
food also plays a major factor, and the environment around us. So being aware of what, when you have a young children at home, so what you're using, starting from all the, be it a washing detergent or anything which you use, which child gets exposure to. If it's toxic, then there is a possible, because today we don't know what are the toxic ingredients which is aware in
Yeah.
any of them.
Don't know, right? So there we can try and avoid heavy metals. We can try and avoid some
Yes,
known carcinogens.
salads.
We can reduce our dependence on packed foods or which sometimes may contain something that
Less
we are
processed
not aware
foods.
of. Although parents are concerned about weight, height, food, they are not really so aware about the developmental milestones which the child should gain after 12 months. So 12 to 18 months or 12 to 24 months is a very crucial period.
During the
Right.
COVID, getting the first vaccination, we were sooner from a
Yeah.
Covishield vaccine.
Covishield and Covax. That was excellent development, and for doctors and healthcare workers, it was available within 6 months or 8 months, I think, after the COVID pandemic struck, and that helped to save a lot of lives. Somehow, the kids were not really badly affected, unlike older adults in the first wave and middle-aged adults in the second wave. Maybe some cross protection from other coronavirus infections which happened during childhood helped the kids to kind of sail through smoothly.
My next question is on the child obesity in your practice. Like, how is it on the rise in India too? Because I see that definitely we have invested. People are oblivion to the fact that that's a concern. So even in adults,
Yeah.
so they don't feel that it is actually a concern, and probably they just go with that fact. It's a new normal.
So it is again lifestyle disease. Again, the side effect of urbanization, both parents working, having less time to cook, and a lack of awareness, easy availability of options, 10-minute deliveries. So
I think
we
a lot
have
of times it's even on the girls. They're not aware of this food habit, it is actually impacting them in terms of getting into a PCOS or even impacting their conception in future when they become old, right? So I think it starts with the teenager or even before that when the whole pattern of eating has set in. So
girls and boys both, it has to be, parents are, the good thing is parents are aware now.
So a lot of times when I've talked to parents, even I have talked to them, how to start having the children like the food and eat. So if you see the pattern, if you see any, I think I can say 90% of the kids today eat with mobile, or the parents cannot feed without showing them a screen or something which is playing, because it is highly impossible these days for the parent to actually ask them to eat food in the growing stage.
Distraction feeding is a big no-no. And it starts right from the time when the child is 7 months, 8 months, when the mother has to resume work. There's a nanny or a grandparent who's looking after the child and who just wants the meal time to be over with quickly. And so it's easy to show screen and just stuff the food when child eats without knowing what he or she is eating. That's why the self-feeding concepts, or allowing child to pick up finger foods, feel the texture, even as young as 10 months, 1 year, all that helps.
One myth about pediatric rheumatology you wish everyone knew this truth about.
These diseases are not rare, but it's a lack of awareness which leads to these conditions not being picked up early. And it's not that there is no treatment option is available, and it's possible to put the child into disease-free remission.
Yeah. If not medicine, what would have been your career?
I don't know, maybe a teacher. Wow. My other hobbies are I like to interact with the youngsters, to teach, mentoring, and I love to read and I write poems. I used to learn dance, Bharatanatyam, so maybe I would have pursued something in arts if not medicine.
Hello everyone. If you like this conversation, please don't forget to hit the like and subscribe button for latest updates in my show, Caffelog with Naga. Thank you so much.